DCIS is the diagnosis that keeps me up at night. Not because it's the most dangerous thing I treat. It isn't. But because I'm often sitting across from a woman who has been told she has cancer. And I genuinely cannot tell her with certainty whether treating it will change her outcome. I'm Dr. Alex Popadich. I'm a breast surgeon and I've been treating DCIS for a long time. What is DCIS? If you haven't seen my last video on what DCIS actually is, I recommend watching that first. I'll link it above. DCIS stands for ductal carcinoma in situ. The cells in your milk duct, they look like cancer cells under microscope. But, and this is a crucial part, they're still inside the duct. They haven't broken through the duct. They haven't invaded surrounding tissue. They haven't spread to your lymph nodes. That containment is what makes DCIS stage 0 breast cancer. Non-invasive. So different from the invasive breast cancer that most people fear when they hear the word carcinoma. And yet, in the vast majority of cases, it is treated with surgery, often with radiation, and rarely with hormone therapy as well. And these options look almost identical to treatments for invasive disease. Which brings us to the question that more and more women are asking, and frankly more surgeons should be asking too. Do you actually need all that? Let me tell you why this question is so hard and why anyone who gives you a simple yes or no answer isn't being entirely honest with you. Here's the problem. When DCIS is found on a mammogram, which is how most women get this diagnosis, we can't just leave it there and watch it. The ethical standard of care is to treat it, which means our understanding of what DCIS would do if left alone is based on a very imperfect data set. Historical cases where the diagnosis was initially missed, or women who were considered too unwell for surgery. So everything we know about DCIS progression comes with caveats. What we do know is this. Without treatment, somewhere between 10 and 60% of DCIS cases would eventually progress to invasive breast cancer in the next 9 to 24 years. That's a huge range, 10 to 60%. And this is not a sloppy science. It's an honest reflection of how much biological variability there is in this disease in all the studies we have so far and imperfect imaging. A bit like flu. Sometimes it's really mild, we just cough or have a runny nose and it goes away. And then some people can die from it. The flip side of that number is the part that doesn't get said enough. The majority of DCIS, possibly the vast majority, would never have become invasive cancer in that woman's lifetime. Flu. Most of us are not afraid of this, but we are afraid of DCIS. And here is the thing that makes DCIS so uniquely frustrating to treat. We cannot yet reliably tell from a biopsy or a mammogram or any test we currently have if your DCIS will progress into invasive breast cancer or not. A bit like we cannot predict who's going to get a mild flu and who's going to get a really horrible flu. And that's the honest clinical reality of medicine. And it's the reason that the treatment conversation for DCIS should not be a single standard protocol. It should be individualized discussion. Now, here is where it gets clinically important and where your pathology report becomes more than just a piece of paper. Not all DCIS is the same. And the single most important variable in this conversation is grade. Let's talk about low-grade DCIS first. Low-grade DCIS, also called grade 1 DCIS, tends to grow slowly. The cells look mildly abnormal under a microscope. They're generally estrogen-driven. And most importantly, studies suggest that low-grade DCIS can take decades to progress, if it progresses at all. The recurrence risk for low-grade DCIS is around 1% per year. So research that models the natural history of screen-detected low-grade DCIS has estimated an overdiagnosis rate of approximately 71%, which means that the majority of women with low-grade DCIS, which is found off screening, this diagnosis may never cause clinical harm within their lifetime. And this is a significant number. We're talking about 60%. And it sits at the heart of why active surveillance conversation is happening. High-grade DCIS is a different entity entirely, and you need to be clear about this. High-grade DCIS has a recurrence rate of around 2% per year, which is double that of a low-grade DCIS. Over 10 years, that sits around 12%. And when high-grade DCIS does progress, it progresses into a high-grade invasive cancer, which carries a significantly higher risk of this cancer spreading and much worse outcomes than invasive cancer that tend to arise from low-grade disease. So because of this, overdiagnosis argument also holds less weight for high-grade DCIS, particularly in younger women. So if we look at women aged 50 to 60 with high-grade DCIS, the estimated overdiagnosis rate is around 20 to 39%, which is quite different to the 61% we see in low-grade disease. So when patients ask me, do I need treatment? The first question I need to know to answer your question is, what is the grade of your DCIS? There is one more thing worth saying about grade, and it's biologically important one. Low-grade and high-grade DCIS are not the 2 points on a spectrum. They are distinct disease entities with different chromosomal alteration patterns and different evolutionary trajectories, meaning they're basically a different disease. Low-grade DCIS does not evolve into high-grade DCIS. Low-grade DCIS tends to evolve into low-grade invasive ductal cancer. High-grade DCIS, if it progresses, it will become high-grade invasive breast cancer. For the past decade, researchers have been trying to answer a very specific question for women with low-risk DCIS. Is it safe to manage without immediate surgery? So 3 trials were designed to answer this. Loris trial in the UK, Lord trial in Europe and COMET trial in the United States. Unfortunately, Loris and Lord trials both closed early before they could enroll enough women to give us a definitive answer. And the reason for that is important. Women found it psychologically very different to accept a watch and wait approach when they have been told they had cancer. And this tells us something that is important about how DCIS is communicated and why the language we use around this diagnosis matters so much. So the COMET trial has given us the most useful data so far. So the COMET enrolled 995 women aged 40 and over with a new diagnosis of low and intermediate grade DCIS. This is grade 1 and grade 2 hormone receptor positive DCIS without any evidence on imaging of these women having invasive cancer. They were randomized either to standard guideline, which is surgery and with or without radiation, or active monitoring with regular surveillance imaging, but no immediate surgery. So at 2 years, so women were followed for at least 2 years, the rate of invasive breast cancer in the affected breast, which means a breast where we found the DCIS, was 5.9% in the surgery group and 4.2% in active monitoring group. This means that active monitoring group did not have higher rate of invasive cancer than the surgery group at 2 years. In fact, the rate was slightly lower, but the difference was not statistically significant. Now, the lead investigator in this study has said herself that 2 years is short follow-up for a disease that can take decades to progress. We need 5-year data and ideally 10-year data before we can confidently offer active monitoring outside of a clinical trial, which means that we still have to wait almost 10 years before we can figure out what is the best treatment for women with low-grade DCIS. But at the same time, this is the most encouraging signal we have that for carefully selected women with low-grade hormone receptor positive DCIS, watching closely may be a legitimate option. I want to talk to you about what a good consultation should feel like, because I think many women may not be getting this. A good treatment conversation for DCIS is not your surgeon explaining what is going to happen to you. It is discussion, the one that starts with your specific grade, your specific size, your age, your comorbidities, meaning the medical condition that you might have, your values, and your preferences. But for a woman in her early 40s with high-grade DCIS, extensive disease, and decades of life ahead of her, the evidence supports treating that seriously and immediately. Because in this group, the risks of undertreatment are real. But for a woman in her late 60s with low-grade, small-volume, screen-detected DCIS, and maybe some other health concerns, the calculation looks very different. The risk of overtreatment, of surgery, its aesthetics, radiation, and the anxiety and side effects that come with all of that may well outweigh the risk of watching closely. But for most women, the answer sits probably between those two poles, which is why the conversation matters so much. So if you've been diagnosed with a DCIS and you're trying to work out whether you're getting the right conversation, here are the things to push for. Ask, what is the grade of your DCIS and what that means specifically for your risk. Ask about the size and extent of your DCIS. Ask whether active surveillance has been considered for your situation, and if not, why not? Ask what the recurrence risk is with and without each component or treatment. Surgery, radiation, and possibly hormone therapy. You are not being difficult by asking these questions. You're doing exactly what informed consent requires of both you and your surgeon. I want to come back to high-grade DCIS for a moment because I don't want anything I've said in this video to be misread. If your DCIS is high-grade, meaning grade 3, the evidence does not currently support active surveillance. The progression risk is higher. The consequences of progression are more serious. And the overdiagnosis argument, while not zero, is significantly weaker, particularly if you're under 60. High-grade DCIS should be treated immediately. The debate about treatment de-escalation is real and important, but it's primarily conversation about low and intermediate grade DCIS. So if you have high-grade DCIS and you're watching this video, hoping I'm going to tell you that you can avoid surgery, I understand why you want that. And I'm not going to dismiss that hope. But the honest answer, based on the evidence we currently have, is that for high-grade disease, treatment, including surgery and radiation, is the right recommendation. This may change in future. Medicine evolves. But right now, that is where the evidence sits. So, do you really need treatment for DCIS? The honest answer is, it depends on your size. It depends on your age and your individual circumstances. And it depends on conversation. A real, honest, properly informed conversation, which takes all of these things into account. If you have low or intermediate grade DCIS, it is completely reasonable to ask about evidence for active surveillance. Not because surgery is wrong, it isn't, and it remains the standard of care, but because informed consent means you are understanding all your options. And if you have high-grade DCIS, the current evidence supports treating it with surgery and radiation. And you deserve an honest explanation of why, not just it has to happen and this is a protocol. The word cancer carries enormous weight. DCIS is not nothing, but it's also not a death sentence, and the treatment decision shouldn't feel like one. You have time. Ask the questions. Push for the conversation. Find the right surgeon who will provide you with all this. In my next video, I'm going to walk through exactly what to expect after DCIS diagnosis. The practical steps, the appointments, the decisions ahead of you, and how to navigate all of it. I'll link it above when it's live. I'll see you in the next one.